Okay, everyone, greetings and good day. Hi, I'm Mike Sharp. I'm the manager of the statistical collection team at SPC in New Caledonia. I'd like to welcome you all today. I was thinking, okay, we're getting quite a few people joining, I think, now. I was actually thinking if it was a small group, we might be able to find time for everyone to introduce themselves individually, but perhaps during the discussion, we'll get to find out who you are and where you're from. But so I'd just like to say a very warm welcome today to the webinar on regional training and strengthening of cause and death data on ICD 11. As I mentioned, I'm Mike from SPC, and I'm here with my colleague Scott Pontifex, who is a statistics advisor, statistical collections, also from SPC. And I'm also thrilled to introduce our two presenters today. Miss Cara Figueroa, who is a CRVS consultant from the University of New South Wales in Australia, and Mr. Nandalal Wijesti-Kira, who is a specialist on MCCD certification and ICD coding, and also health information systems. And Nandalal is working with SPC to provide technical assistance to implement the program of activities that we're here to present to you today. So from SPC, just I guess a few opening messages and remarks from us. So firstly, data on cause of death and ICD classifications and coding are essential inputs to planning, managing, and evaluating the performance of the health sector. And they're needed for accurate monitoring of population health, identifying health priorities, and evaluating health program impact in the Pacific region. Information on cause of death provides valuable context for a broad range of social development investments pertaining to education, social security, gender, and child protection. This is particularly important in the Pacific due to the need to continue to monitor and report progress against the Sustainable Development Goals and the need to respond to the impact of non-communicable diseases. In addition, the rise of non-communicable diseases has meant that many of the traditional methods for calculating life expectancy and adult mortality from census data are less reliable, as the models used in many of these calculations do not sufficiently account for these increasing premature adult deaths. Civil registration and vital statistics are therefore an essential source of population data. The short program of activities that are to occur over the coming 3 months have the objective of, firstly, establishing national relationships, networks, and focal points for the development of cause of death statistics, and to coordinate the engagement of partners. Secondly, to understand opportunities to further increase capacity of national vital statistics systems to develop death registration, medical certification, and cause of death coding. Thirdly, it's to provide opportunities for doctors and coders to participate in medical certification of cause of death and ICD mortality coding capacity building initiatives. And finally, it's to make plans for ongoing technical assistance of SPC in relation to mortality coding and to further develop innovative solutions such as automated coding and in the establishment of a regional cause of death coding centre. The program of activities is funded by Bloomberg Philanthropies Data for Health through the Vital Strategies and the CDC Foundation, for who we acknowledge with great thanks. So at SPC, we're thrilled to announce our renewed capacity in the CRVS space. Sorry if it's not clear to everyone. I'll try and speak up for you guys we'll see if it can be solved as I talk through. But so at SPC, we are thrilled to announce that we have renewed capacity in the CRVS space. We have the aforementioned program of events, but soon we will also recruit a statistics advisor with a focus on civil registration and vital statistics for a period of at least 3 years starting early next year. So that person will join the statistical collections team at SPC that I manage and have worked at, but we've worked more sort of on the consumption statistics side of things. So our main objective has been to reduce mortality or premature mortality as a result of dietary related non-communicable disease. And we also provide assistance to the Pacific Island countries in conducting population and housing censuses. So we therefore have a great interest in developing CRVS systems, which are an essential element towards the development of population-based registers. And they are also highly complementary to the Pacific Census programs. These statistics are also essential to report on the incidences of mortality statistics associated with sexual-based violence and disease, and they're required to report against at least 8 of the 132 Sustainable Development Indicators as part of the Pacific Roadmap for Sustainable Development. So with well-established international networks, including the Brisbane Accord Group, the Pacific Registrars Network, Pacific Health Information Network, and with a supporting strategic framework, including the Pacific Vital Statistics Action Plan and the recently developed Strategic Framework for Pacific Statistics 2020 to 2030, we look forward to increased capacity at SPC towards contributing to the development of CRVS statistics in the Pacific region. So once again, thank you for joining the webinar today. So I hope you can hear us. I will share these opening remarks, and I think it could possibly be a problem with my microphone. So I do apologise if you can't hear, but I will share these remarks with you so you can read them at your leisure. But we hope that you have a productive and a productive session today, and we look forward to ongoing engagement. So as for the session today, we will have 3 presentations followed by a group discussion and some feedback. So Cara will firstly take us through the first session to give an overview of the program, and she'll then pass over to Nandalal for 2 sessions. The first on cause of death and mortality coding, followed by an overview of ICD 11. After the presentations, Cara will facilitate the group discussion, and she'll present to us the upcoming program of events for the next 3 months or so. So just a few administrative points. The webinar is being recorded, so I hope that's okay with everyone. We do plan to make it publicly available so those who cannot attend can catch up. And if you have some questions, please put them in the chat or save them for the discussion at the end. So once again, I'd just like to say a great thanks for joining, especially during the festive time of year. We really appreciate you taking the time to be with us, and we're extremely excited for this webinar and the program of events that are to come. So wish you a good session. Thanks again, and over to you, Cara.
Thanks, Mike. Hi, everyone. I'm Cara. I'm working with Mike and Scott as the coordinator for this program on strengthening cause of death data in the region. And in this capacity, I'm working with them, SPC, and to support engagements with national and regional CRVS stakeholders and health information system stakeholders, government and non-government agencies, liaising with them and between them, coordinating trainings and workshops and meetings like these. And I also work closely with the Brisbane Accord Group partners and their CRVS efforts and activities as well. In this session, I'll provide an overview, as Mike said, highlighting some background information, previous activities that this project hopes to build on, the goals, the objectives, and our activities planned for the future. So why do we have this in place? Well, the availability is probably a lot of you know, and the quality of cause of death data are fundamental challenges for most countries in the Pacific Island region. And this mainly stems from weak death registration practices and inaccurate or inadequate capacity in medical certification for and coding of causes of death. And with respect to coding, there are critical challenges in maintaining qualified staff, especially in the small island countries. And there can be a limited technical knowledge as well among relevant officials. So it's really crucial to ensure an integrated, a comprehensive, meaningful action and programs and training programs to effectively improve the quality of cause of death information in countries that would enable governments and public health officials to make informed decisions regarding policies and health and development programs. And Mike highlighted earlier the importance and value of mortality and cause of death data and the benefits of having these improved statistical systems. So in recognition of this need for accurate, reliable, quality data on deaths and cause of death, previous heads of health meetings have made recommendations for governments to continually improve national health informations and CRVS, as well as recommendations for development partners to continually support countries in their health information system strengthening efforts, and to strengthen institutional capacities as well. And heads of health meetings have also endorsed the commitment to really improve data, particularly on deaths and causes of deaths from CRVS systems, and actually stating the need for that regional cooperation with networks, with the BAG and other stakeholders in this area of work, and to have that supported by SPC. There's also been recommendations and commitments from the heads of planning and statistics as well, who obviously recognise the important role of civil registration systems and highlighting the need to support their development in the region as well. Pacific Island countries have also made commitments to strengthen progress towards the goals of the Regional Action Framework for CRVS in Asia and the Pacific, and to achieve by the end of the Asia Pacific CRVS decade their own sort of national goals and targets as well. And we know countries are committed towards achieving the SDGs and other regional, like the Healthy Islands Monitoring Framework. What has been done before? Well, and what does this project sort of build on? Over the past decade or so, several countries have taken part in regional, sub-regional, and national level training on medical certification and coding, ICD coding of causes of death on an ad hoc basis. And those trainings have adopted a training of trainers approach. Several countries have also had quality reviews of their cause of death data. And the activities have been implemented with the phenomenal, tremendous support of experts and funding, particularly from BAG partners like the Australian Bureau of Statistics, QUT, Queensland University of Technology, and the WHO. And in addition to that, in more recent years, since 2020, with the support of Bloomberg Philanthropies Data for Health initiative. SPC has also conducted, I guess, a needs and capacity assessment as well on certification of cause of death and mortality coding, ICD coding, among selected countries, focusing on the availability, the distribution of doctors and health facilities as a way of targeting capacity building activities better. They've also developed with relevant partners an initial proposal for a regional centre for coding causes of death and published sort of regional training curriculum for medical certification and a regional training curriculum for mortality coding of cause of death as well. And we can talk more about those later in the discussion. So participants from previous training programs or workshops have really highlighted a few areas of improvement, and a lot of these some of these are on the slide, like the need for a structured program or standardized training program as well. But really, importantly, there does remain a need for a more systemic approach and a framework for countries to for continuing the support provided by partners like those within the Brisbane Accord Group, and the support they provide to countries and the region, particularly through strengthening cause of death certification and coding practices, and a real need for a framework to develop institutional capacity to ensure sustainability of the skills development and to have that translate into more long-term improvements in mortality and cause of death data availability and quality. And there is, this specific recognition to have these local solutions as well. These are sort of the two sort of primary objectives of the project in more short-term and long-term goals. So we want to build a pool of Pacific Island professionals who can train their peers and lead capacity strengthening efforts in the region. So we want to be able to try to institutionalize this training, to support those who have already completed the training. And in more longer-term sort of planning, this more centralized coding support for countries who have really who are interested in having this centralized coding support. So the activities are sort of in 4 areas: providing training and education support on medical certification of cause of death, including providing direct training and training and trainers workshops, providing training and education support on coding, ICD-10 and ICD-11, and we also have a planned face-to-face workshop, and I'll talk about those upcoming training workshops in the next slide. There are also discussions with regional academic institutions such as Fiji National University to implement the more standardized training programs and curricula that have been recently developed, and having also short courses. As for the third point in this slide, regional ICD mortality coding support, such as advancing the initial proposal for having this regional coding centre, implementing automated coding tools, providing technical and mentorship support as well, like through staff attachments and things. And these are all things that have been discussed in various sort of forums, and we can also discuss them later as ways that you might be interested as well. These upcoming training workshops will also cover these sort of activities as well. The last point, additional country technical assistance. So that would be like supporting and training medical record staff or health information staff in data quality assessments or data analysis and statistics, or producing vital statistics report and how to use the usage of those vital statistics as well. So these activities were actually making use and utilising the large amounts of training, existing training materials and support tools and resources that are available and that have been developed in recent years by BAG partners, as well as supported by the Bloomberg Philanthropies Data Health Initiative, and also actively engaging agencies, government agencies, especially in the Departments of Health and Statistics, and governmental partners, and supporting their efforts as well to align their capacity building efforts in this space as well. So these are sort of the upcoming events and workshops. WHO are interested in working with us in having a jointly developed webinar specifically focused on ICD-11 and related tools, and that would be planned for mid-February. The objective is to really ensure countries are aware of making informed decisions and of their considerations when deciding to transition to ICD-11. We have a planned 2-day hybrid training workshop on MCCD, and that would be followed by an extended 9-day face-to-face training workshop on coding in Nandi. The training workshops will also include sort of sessions to really assist participants to really build their proficiency in skills required to conduct national training themselves. Nandalal is our expert trainer, and he can provide further details on the actual format and the activities involved. It's hoped that trained doctors and coders could also be invited to facilitate future trainings. So if you know of others who have been who've taken part in previous workshops, yeah, please do get in touch. And during this webinar and in these sort of upcoming workshops, there will also be time for participants to really discuss their needs and preferences, their ongoing needs for support in this space, and to raise queries about ICD-11. So this is not the only opportunity. And we also have provided a questionnaire covering some key technical areas. So for those joining today and you haven't completed it, you can complete it during the group discussion later as we'll be going through it, or complete it in your own time before these upcoming workshops as well. The questionnaire is really designed for you. It's to help us better assist you. Yes, so the project is supported by Bloomberg Philanthropies and has been supported, and it extends the work by experts and technical advisors from BAG partners. I'll now pass it on to Nandalal to provide an overview of medical certification of cause of death, then ICD mortality coding, and followed by an overview of ICD-11.
Thank you, Cara. I need to share my I'm sorry, I'm unable to share my screen. Can you please share my first?
Something's coming up, but it is still great.
Coming up?
Oh, yeah, it was just slowly appearing.
This one?
Yeah, now we've got it.
Okay. hope you can see my screen now.
Looks good to me. Thanks, Nandalal.
Thank you. Hi, good morning and good evening to all of you, and thank you very much for joining this webinar. I'm Nandalal, and I think most of you know me. I have seen a lot of familiar faces, and I'm working as a MCCD certification and ICD coding expert, and I'm based in Sri Lanka. I'm working for both Ministry of Health Sri Lanka as well as Vital Strategies and now SPC. Right. Okay, so we will now have a look at the overview of medical certification of cause of death and ICD mortality coding. So my plan is to show you why medical certification of cause of death is important, the quality of cause of death certification across the world, about the definition of causes of death, the concept of underlying cause of death. Then I will show you an overview of ICD mortality coding and mortality coding rules during this session. So if you take causes of death, then now this is done for mainly planned for doctors. So as doctors, we are trained to treat patients and save lives. So why are we more concerned about certifying deaths? So what is the importance of certifying deaths? Because medical certification of cause of death is an important part of doctors' duties. The information recorded in a medical certificate of cause of death helps decision makers determine health priorities for prevention of deaths due to similar causes in the future. So that is the importance. So it is very important that the doctors certify the causes of death accurately. So if you take the quality of causes of death information across the world, you can see these dark green areas give us very high quality causes of death, and the light green areas medium high quality, and it goes down when if you look at the very dark brown areas, they do not report any causes of death at the moment. So I'm sorry, the Pacific Island countries are in very small areas. It doesn't show anything, but I know they are also either they don't report or the quality is not very good. So we have to improve the quality of causes of death in the Pacific Island countries also. So what is cause of death? So this is the definition given by the World Health Organization during the 20th World Health Assembly in 1967. The definition of cause of death, which is valid even today, is all those diseases, morbid conditions or injuries which either resulted in or contributed to death, and the circumstances of the accident or violence which produced any such injuries. So why do we have a definition like this? So the purpose of the definition is to ensure all relevant information are recorded in the MCCD, and to ensure the certifier does not select some conditions for entry and reject others, and also does not include symptoms and modes of dying such as heart failure or respiratory failure or cardiorespiratory arrest. Okay, we know when the heart stops or when you stop breathing, a person dies. So there is no need to document that. What we need is the condition or the cause of death, the condition of how they died. So there is another concept, the concept of underlying cause of death. So when only one cause is recorded by the certifier, this cause is selected for tabulation, and this reported single cause becomes the underlying cause of death. So it is very easy when there is only one cause of death is recorded by the certifier, meaning that there was only one cause for this person's death. But when more than one cause is recorded, there is a need to select a single cause for reporting. So this selection is done by the coders using ICD mortality coding rules. So when the certifier records more than one condition, then when it goes to the ICD mortality coders, the mortality coders will apply the mortality coding rules and will select one single cause for reporting. So this single cause is usually given the special name, the underlying cause of death, or we call it UCOD. Therefore, the underlying cause of death is the condition or event or circumstance without which the patient would not have died. So that is the starting point of this, of the whole course. So the underlying cause of death is the disease or injury which initiated the train of morbid events leading directly to death, or the circumstances of the accident or violence which produced this fatal injury. Underlying cause of death is reported in the lowest use line in the medical certificate of cause of death. So it should be, so this is valid for MCCD which is correctly filled out. So in a correctly filled out medical certificate of cause of death, the underlying cause of death is reported in the lowest use line. If not, it will be changed. So in the train of morbid events, it is the last wagon which is important. For example, I will take this example. A cancer patient dies and the immediate cause of death was congestive cardiac failure resulting from carcinomatosis. That means widespread dissemination of carcinoma in the body, or the secondaries or metastasis. And the original neoplasm site was colon. So the train of morbid events, it starts with the, so the death was due to congestive cardiac failure. It was due to the
Nandalal, just you're on mute. Sorry, somehow you're on mute.
sorry. From where? From this slide?
Yes, just like 30
okay.
seconds.
Okay, let me. So I will go back. I will take an example.
Nandalal,
Yes.
Sorry to interrupt. One of our colleagues is having problems in FSM. Do you mind if we email them your presentation?
Yeah, definitely.
Okay, we'll send that across now. Sorry, everyone.
Yeah, no worries. So a cancer patient dies, and immediate cause of death was congestive cardiac failure resulting from carcinomatosis, and the original neoplasm site was colon. So the train of morbid events leading to death for this case is he died of immediate cause of his congestive cardiac failure due to carcinomatosis due to malignant neoplasm of the colon. So the immediate cause of death is congestive cardiac failure. The underlying cause of death, or the starting point, is the malignant neoplasm of the colon. So it all started with the malignant neoplasm of the colon, that led to a carcinomatosis, led to a congestive cardiac failure and death. So, if there was no malignant neoplasm of the colon, there will be no carcinomatosis, there will be no congestive cardiac failure, and the patient would not have died. So the starting point is the malignant neoplasm of the colon, and the terminal event is the congestive cardiac failure. So that is all about the medical certification of cause of death. So the detailed explanations on medical certification of cause of death, please join the workshop in February 2023. This is for physicians who carry out MCCD certification, and we conduct this for 1.5 days, and there will be presentations on MCCD certification, and there will be some group work, individual work using case scenarios. So, so for detailed explanations on this, please join the in-person workshop in February, which is also hybrid workshop. Now I will go straight to the overview of ICD mortality coding and coding rules. This is just an overview. With this short period of time, I won't be able to give you all the aspects of mortality coding. So it will need a lot of time, but I will give you an overview. So what is coding? So coding is the translation of diseases, health-related problems, and procedural concepts from the text to alphanumeric codes for storage, retrieval, and analysis. So we cannot store or retrieve or analyze the causes of death written in letters or words by the certifiers. So to do this analysis, we need to code these causes of death. So why do we code? Data contained in medical records is of no use if it cannot be accessed, retrieved, analyzed, and used. So that is why I told you the words written by the doctors is of no use if you can't analyze them. Therefore, for easier storage, retrieval, and analysis of data, we code them. So what are the purposes or uses of coded data? So this is needed for continuing patient care, clinical research and epidemiological analysis, funding and resource allocation, health services planning and evaluation, and we need them for quality assurance. So I will just go through how we apply mortality coding rules to select the underlying cause of death. So the World Health Organization has defined a set of procedures or coding rules to be followed for coding the causes of death. So many coding instructions are based on ICD codes. So first thing we have to do, the first step would be to code all the conditions recorded by the physician or the certifier in the medical certificate of cause of death. So that is the first step. Then we need to select the underlying cause. So the selecting of underlying cause of death involves two separate steps. First is to identify the starting point, and then to check whether any special instructions apply to starting point and whether it modifies the starting point. So we first identify the starting point, and then we check whether whether there are any special instructions to modify this, which will modify this starting point. Identification of the starting point involves 8 steps. So there are 8 steps in identification of starting point, and these steps are described as SP1 to SP8. So that means the starting point rule 1 to starting point rule 8. And Each of these steps contain one selection rule. So we apply accordingly, starting with SP1. If we fail that, we go to SP2. Like that, we go to up to SP8. In most cases, the underlying cause of death is the same as the starting point. So most cases, not all. However, sometimes a condition other than the starting point is selected as the underlying cause of death for use in the statistics, and this is called modification. So this is done by the application of modification rules M1 to M4. So for these details, please join the in-person ICD coding workshop in March 2023, because then I will elaborate on all these rules and I'll show you how to apply these starting point rules and the modification rules. Well, thank you. And I will now straight away go to the ICD-11 overview. Hi again. I hope you can see my new screen. Is that so? Can somebody let me know whether you can see my new screen?
No, we can't see your new screen yet, Nandalal. We can just see your slides, your previous slides.
Okay, let me. Can you see now?
Yes.
Yeah.
Okay, thank you. So I will now go through an overview of the ICD-11. So my plan is to show you the history of ICD briefly, why ICD-11 was developed, the key facts about ICD-11, then ICD-11 improvements from ICD-10, about the ICD-11 homepage, including the ICD-11 self-learning, self-training package. Then the use of ICD-11 coding rules and conventions for step-by-step coding. There are some new terminology in ICD-11, so I will go through them also very briefly. Then I will talk about the ICD-11 coding tool with the basic coding scenarios and coding examples. And there is a ICD-11 automated coding tool called the Doris. I will show you that also very briefly. So the history of ICD. So the history goes back to 1700s. The first attempt to classify diseases systematically was done by Sir George Nibs and Francois Bossier de Lacroix in 1700s. In 1891, the International Statistical Institute in Vienna started preparation of a classification of causes of death, and it was suggested that classification should be revised every 10 years. So with that, revisions were done in 1900, 1910, 20, 29, and the fifth revision was done in 1938 in Paris. So then the WHO was given the responsibility for the next revision. So the next revision was done in 1948 with the, it was done by, from here, the WHO the World Health Organization took over of all these revisions. So the sixth revision under the patronage of WHO was done in 1948. Seventh was in 55, 8, 65, and ninth revision was in Geneva in 1975. So the 10th revision, or the ICD-10, began in 1983 in Geneva, and there was no revision done for the next 25 years because the ICD-10 was so good, and there was no necessity to change this to the next revision up to now. But in 2007 April, the WHO announced the beginning of the work to create a new the next revision of the ICD, known as ICD-11. So the ICD-11 was submitted to the World Health Assembly in 2017, and it is expected that the full implementation would be from 1st January 2023. That is just about 2 weeks from now. But I have put a question mark on this because we are not still sure whether the countries are ready for this next revision. So it might take a bit longer than this date for full implementation. So why ICD-11 was developed? So what are the key facts? The global standard for health data for clinical documentation and statistical aggregation. So they have to develop. The WHO wanted to have a better revision than ICD-10. So this ICD-11 is thoroughly and scientifically updated and designed for use in the digital world. So now we are in a digital world. So this ICD-11 is updated or designed for use in a digital world. So it is in the state-of-the-art technology, and it reduces the cost of training and implementation, because its training of ICD-11 is much easier than ICD-10. And it is already in multilingual design. It facilitates global use. It is already in French, Spanish, Arabic, and Chinese languages, and they are going to translate this into several other languages in the future. So what are the improvements of this version or revision from ICD-10? So ICD-11 is a vast improvement on previous revisions, so mainly from ICD-10. So it reflects critical advances in science and medicine. There is more meaningful clinical content than ICD-10. So there is more meaningful clinical content. So this is good news for the physicians. There is a significant feature of ICD-11 is the improved ease and accuracy of coding, requiring less user training. So this needs very much less user training, and it is very much easy to handle. ICD-11 is digital health ready for use in multiple IT environments. So unlike ICD-10, ICD-11 is very much digital health ready. Therefore, it could be used in multiple IT environments. ICD-11 translation tool ensures internationally consistent translation and the addition of locally used terms. So for ICD-11, you can, I'm sorry, okay. With this ICD-11 translation tool, it ensures internationally recognized translations, and additionally and you can add the locally used terms also into this. And also there are a lot of new chapters in ICD 11 from ICD 10. So there is a new chapter for diseases of the immune system, sleep-awake disorders, and conditions related to sexual health and traditional medicine. So traditional medicine was not there in ICD 10. It is included here. The overall coding improvements in ICD 11 allows more precise and more detailed data recording and collection. So I will show you later what these detailed data. For example, they include codes for antimicrobial resistance. So the codes are not there for antimicrobial resistance in the previous versions. Their details necessary for cancer registration is fully embedded in ICD 11, and there is a specific coding for clinical stages of HIV and more clinically relevant coding for complications of diabetes. And there is a significant improvement in coding for traffic accidents and injuries. So these are the improvements from ICD 10 in ICD 11. So if you look at the ICD 11 homepage, which includes the ICD 11 self-training package, if you log on to this URL, you will go to the homepage of ICD 11. For now, we will not go for this. It is something like this. So if you log on to this URL, you will see this homepage, and it contains use of ICD 11, the ICD 11 browser for seeing the content. You can go to ICD 11 coding tool for coding of ICD, coding of causes of death or diagnosis from ICD 11. We have the ICD API for web services to get programmatic access to ICD 11. And we also have the ICD 11 implementation or transition guide. It also contains the ICD 11 reference guide, which is equivalent to the volume 2 of ICD 10. It gives you all the coding instructions and everything is there in this reference guide. Then you can learn more about ICD 11, ICD 11 fact sheet, the license, and the ICD 11 self-training package is also in this homepage. And it do also have the older versions, the ICD 10 browser. You can log on to the ICD 10 browser from this homepage, and there is a maintenance platform which provide various ways that you can also contribute. So those are the contents of the ICD 11 homepage. What are the users of ICD 11? The use of ICD 11 coding rules and conventions for step-by-step coding. So I will just show you the outline. So ICD 11 coding step by step. So this is not going, I'm not going to show you all the how you do it, but I will just show you the steps because the time is limited. So the essential component of coding is finding a match to the reported clinical term. That is the one that is recorded by the physician. So to do this, the coders should know the ICD 11 coding rules and conventions. Now, people who have who know about ICD 10 coding conventions and coding rules, all these are similar to ICD 10. So there will be inclusion notes, exclusion notes, the NECs and the NOS, certain or residual categories like other and unspecified, use of an or due to and associated with conditions. Then about the spelling, the British and the American spelling, the parentheses, grammar and other conventions. So these are almost similar to ICD 10. Well, there are some new terminology for ICD 11. So what are they? So we have in ICD 11 there is a term called the STEM code, the extension code, pre-coordination. There will be post-coordination. These are the new terminologies. So or has manifestation, cause, the laterality. If it is a fracture subtypes, open, close, associated with or joint involvement, etc., etc., there will be a lot of post-coordination. Then another term is a cluster and primary and secondary parents. So these are the new terminology which is new to ICD 11 from ICD 10. So for details, we will have this workshop in March 2023. Please join this workshop for more details on this. So ICD, now we are going for this ICD coding tool. So there are various basic coding scenarios. So when you go to the ICD 11 coding tool, when searching a diagnostic term, a coding tool would give a blue highlighted STEM code. So if I have time, I will show you these. But if I don't have time, well, we will do this in March. Then the STEM code with extension code, that is the automated indexing of a post-coordination dimension for anatomy, laterality, etc. Or STEM code with mandatory post-coordination with a red icon and a green coding note, or STEM code with optional post-coordination where will be a gray icon, or flexi search option. So when you go to the coding tool in ICD 11, you will have one of these coding scenarios when trying to code a diagnostic term or a cause of death. So I will just show you what is this blue highlighted STEM code. So this I took this example. You can see Hutchison-Gilford syndrome is blue highlighted. So this is called the blue highlighted STEM code. I know you will not understand this now, but to understand this, you need more time and more explanations, which will be given during the March 2023 workshop. The search STEM code with the extension code, you will see now the breast cancer, right? Now this feature was not there in ICD 10. This is called the laterality. So the right, we can code right or left. So this is the extension code. So you can see there is an extension code in blue, NXK9K, which is circled in red. So this is a example with STEM code with extension code. Now STEM code with mandatory post coordination, you will see it is not blue highlighted, it is brown or brown highlighted, and you will see the red icon in the coding tool, so that you have to have there will be mandatory post coordination. So this is not the final code. You will have to do something more to find the final code. Then STEM code with optional post coordination, there will be a gray icon, and that means you may do a post coordination and see whether you can add more detail into this. And the last scenario is the flexi search option, where there is, when you enter the diagnostic term or the cause of death, the coding ICD 11 coding tool will not give you a prompter code, where then you will have to go for a flexi search. So all these things I will explain during the face-to-face training. So I will now take a coding by use of an example, ICD-11 coding. So take this example, ICD-11 coding example, fracture of right humerus. So what we have to do first thing, the step one is to log on to ICD-11 coding tool, mortality and morbidity statistics. Next step is to type fracture of right humerus in the coding tool. So the fracture of right humerus will give you this ICD-11 code. You will see this ICD-11 code is very much different to ICD-10 code. So this stem code is the fracture of right humerus, which is NC 12.3. And the extension code for right is XK9K. And since the physician has not said that this is open or closed, we take it as closed. That is a rule. And that is the XJ44E is the extension code for the closed fracture. So, that is how we code. So if I have time, I will go to the coding tool and show you how you do this. But if I don't have time, let me do this during March 2023. So now I'm coming to the ICD-11 automated coding tool, or the Doris tool. So the WHO has designed an automated coding tool called Doris. Doris stands for Digital Open Rule Integrated Cause of Death Selection Tool. So this tool is for selection of the underlying cause of death, and this is done automatically. It is developed by, as I told you, it is developed by WHO to compute the final underlying cause of death, or the final U code, automatically. Now this tool is able to compute individual medical MCCDs as well as multiple MCCDs, that is batch processing. So you can compute, or you can find the final underlying cause of death individually, or you can enter a series of MCCDs into this tool and find the final underlying causes of death for all those MCCDs at the same time, which is called batch processing. So access to Doris tool, you can log into this page, and you will come to this Doris tool. But so these are these are the things, or the points that are very positive points. But the only negative point is this tool is still in the developmental stage, and the final version is yet to come. So it will take some more time for the final version to come. So until then, we will have to do the manual coding. So details will be done during the in-person workshop in March 2023, as I told you earlier. For more detailed training in ICD-11, please join the in-person ICD coding training in March 2023. Thank you very much, and thank you very much for listening. And I think I have, if you can give me another 5 to 10 minutes, I can show the ICD-11 coding tool practically. Can I have 10 more minutes?
Yeah, go ahead, Nandalal, if others are okay with that, because you're on time, you're on schedule. So.
Okay, thank you. So I will now try to go to this ICD-11 coding tool. Can you see my screen? ICD-11 coding tool.
Yes.
Okay. So I will try to now code the fracture right humerus. So I will type fracture.
Sorry, we see your slides, but not the website.
Oh, I'm sorry. Let me. Okay. Can you see now?
Yes, thank you.
Okay. Thanks. So my example was fracture right humerus. So I have logged on to ICD-11 coding tool. So this is the ICD-11 coding tool. So what you have to do is you have to enter the diagnostic term or the cause of death. So I took my example as fracture right humerus. So we'll type fracture. Okay, as soon as you can see, as soon as you type fracture, it will give you all the fractures. So which is very easy, it's much more easier than ICD-10. Okay, so we will go to fracture right. Then it will give you all the fractures where there is a right-sided fracture. So that is called the laterality, fracture right. So now we will go for humerus. So as soon as you enter, even not even before you enter all the letters of humerus, it will give you the humerus. So you can see now fracture of humerus right here, and you can see it is blue highlighted. That means it is a complete match. So when you can go for details, and it will show you fracture of humerus right. So one doctor will write fracture of humerus right, another doctor will write fracture of shaft of humerus right, or various other things. So all those are given in this ICD-11 coding tool, which becomes very easy. And now I told you there is you can do post coordination. When you say post coordination, you can add more detail. So you will see the right. So the fracture of shaft of right humerus is already selected because I entered right. So the stem code is NC 12.3 and the extension code is XK9K for right. Now, since the doctor has not said whether this is an open or closed fracture, as ICD coding rules, we take it as closed. So we can go down and see whether we can add that extension code also. So here you can add that. So when you click on this close fracture, it will automatically add to our code. So now the final code, the stem code is NC 12.3, and the two extension codes are XK9K for right, that is called the laterality, and since the doctor has not said that this is open or closed, we take it as closed, and the code for extension code for this closed fracture is XJ44E. So so what we can do is we just click. If we just click on this select, it will copy all these codes, and you can just go and paste wherever you want. So which is going to be very much easier than the ICD-10. So so I hope you got a outline of a medical certification of cause of death, as well as coding rules, and then the overview of ICD 11. So I hope you will join the March 2023 in-person workshop so that you can learn more about ICD coding rules as well as ICD 11. Thank you very much. And it's over to you, Kara, now.
Thanks, Nandalal. That was incredibly insightful, and I learned quite a lot there.
Thank you.
So, did anyone have any questions about the previous presentation? If so, post them in the chat. I don't think we've actually had any current. Someone's given you a clap. I don't know who it was, but I'll also second that. Round of applause.
Thank you.
Oh, that was Mike. That's great. So there's no current questions in the chat, but I'll give you opportunity for any new questions that participants or those joining the call might have.
I have a question, if you don't mind.
Gillian, you can go. You can first introduce yourself as well if you
Oh,
like.
sure. Hi, everybody. My name is Jillian Dunn. I am the HIS coordinator for PAHOA. PAHOA works with the U.S. affiliated Pacific Islands. And I was wondering if an app is being developed for ICD-11, or is it going to be primarily a website-based kind of application that you showed?
That is a website-based application, but if somebody wants to do it, there are places where there is no internet. So for that, to plug that in, they have this. The WHO has developed this app so that they can download it and use it offline.
That's great. That's exactly the scenario I was thinking of in areas of low connectivity or areas where people don't have ready access to a laptop. Thank you.
Yes, thanks.
Thanks, Gillian. Nandala, could you just post the link to the actual website where you do your demonstration on the browser, just for our colleagues at FSM and others who couldn't see your screen? But of course, and I'll emphasize again that we will be sharing the recording of videos as well. So just in those the last few minutes when you did the demonstration, just to put that in the chat, if that's possible. And Tanya's said maybe our WHO colleagues can expand on the ICD-11 app and how it will be intended to be used. Yes, that's something that our colleagues at WHO would be able to do as well. And as I said at the top of the webinar, we'll also be having a planned webinar with them to really focus on the related tools of ICD-11. And actually how we can really support countries in their implementation plan and strategies as well. Mike has commented, is poor diet a cause of death? It's something that I have seen on the death certificate. And yeah, you have to be very specific about what constitutes a poor diet. but normally certain risk factors, dietary risk factors, particularly modifiable ones like high cholesterol or something like that, they generally have to be, well, not have to be, but they're like contributing causes of death. And so generally speaking, having them in the causal sequence, like in certain parts, part 1 and part 2 of the medical certificate, that needs to be properly written down. So it's usually in the in the contributing factors section. Nandalal?
Yes, poor diet is definitely not a accepted cause of death. It is it will go as an ill-defined condition. Then the correct cause of death would be the consequences of poor diet. There will be various consequences, and as COC has said that very correctly, that it is ill-defined. Yes, definitely it is ill-defined. So you can't have if you just put poor diet as a cause of death, it will go as a ill-defined condition, and the correct cause of death would be the consequences of this poor diet. There will be various other the diseases or conditions. And then Scott is asking another question. Can I just answer that question? Are there any significant rule changes in sequencing to determine underlying cause of death from ICD-10? Well, there are absolutely no rule changes. For ICD-10, it is the rule step SP1 to SP8 and the modification rules M1 to M4. These rules SP1 to SP8 and and M1 to M4 prevails in ICD-11 also. So there will be no change. You don't have to worry. People who know about ICD-10 rules, it is going to be the same rules for ICD-11 also. Hope I explained it correctly, Scott.
Okay, I'll move on. If there's other questions, definitely feel free, put them in the chat. We'll be monitoring that, and then we can try and answer them. So we'll spend the rest of the webinar, the time we have left, or we can even have an early mark, just to really have this is more intended to be a group discussion of specific country supports and regional level supports for medical certification of cause of death and coding, support and technical assistance delivered by the BAG, and of course your queries about ICD-11, both how it works and the rules and conventions, but also perhaps at an implementation and operations level. I'll try and moderate this discussion, or semi-moderate. I do have a few slides to sort of guide the talking points. And we have a few partners, regional agency partners who have joined the call, and are more than welcome to provide their insights as well. I want to emphasize that for those country participants who are now with us joining, as well as who are probably listening later, we want to be flexible as well as feasible wherever possible, and responsive to your local capacities and experiences and needs, and your preferred approaches to capacity building in these cause of death straightening areas. And that'll really inform the future project activities and those of the Brisbane Accord Group as well. And as I've also mentioned earlier, there will be sessions in future workshops as well, dedicated to discussions like these as well. I just wanted to highlight some of the previous sort of assessments that have been done on a regional level. So the bags through SPC, I think it's about 2018, did try to assess the basic capacity needs of coding of cause of death in the region, and some countries provided feedback on their preferences, whether they wanted for sort of in-country training, formal training, or on-the-job training, centralized coding support. And that was also submitted alongside another questionnaire that SCAP also submitted related to more to certification as well. So we're hoping for these sort of time period and current time period and moving forward also, we're hoping to expand and extend the previous survey assessments as well on capacity building needs and preferred approaches. And the questionnaire really aims to capture that more up-to-date information, to reach out to more countries and stakeholders, and to actually specifically assess the potential impact of COVID-19 on both the activities of medical certification and ICD coding, as well as the actual training activities as well in relation to those areas. So if countries do require support in specific areas, do please. Oh, sorry, which questionnaire on certification from SCAP were you referring to? Yeah, so thank you, Tanya. So just to clarify, these the questions that are sort of captured also are relevant to also reporting and assessing progress against the regional action framework for the CRVS decade. So there was a certain alignment as well with the midterm questionnaires as well. Yes. So that also reinforces, when you bear that in mind, that that this questionnaire is really helping to guide those activities as well, and to help monitor the progress for the regional action framework as well. So it is to your benefit to fill this in, because we do coordinate with those BAG partners and with SCAP as well. I've just got this slide just to provide your previous training experience as a doctor or as a coder when you're filling in the questionnaire as well. That would be helpful. There are a few sections, so with the medical certification of cause of death, there's the sort of basic questions on training needs, and then a set of questions on preferences. So whether you want a periodic quality review or whether that might be needed of your certification data. Standardized training of previously trained doctors. So there is a package that the Brisbane Accord Group collaboration has developed for these training workshops, and it has been sort of adapted and used, and it's why it's great that we're having workshops as well to continue to use that training package and adapt it and refine it. So that's something that countries can also feed back to us if they need more of that standardized approach as well. Or whether you would need ad hoc training, certified online short courses. So I could speak more to that later, but as I said, we have had discussions with regional academic institutions like FNU to provide more short courses and online that could be readily available and accessible to not only doctors, but to those who are interested in that sort of skills development. There might be a need for support to establish or to strengthen a national mortality technical working group, or having the audit committee, the committees or mortality review committees, the committees within hospitals strengthened as well in their functioning. That's something to consider. So having them better function to oversee the quality of medical certificates of cause of death or clinical records that help inform doctors determine the cause of death. Whether they can also provide an opportunity for ongoing continuing medical education for doctors to help them stay up to date with their skills or to set training requirements. That's if there's a need for that sort of support for a stronger audit committee, again, let us know. Before I move on to the next slide, was there sort of things that I've just pointed out that you may want to comment on or have that you're unclear on? Is that something that perhaps your countries might be interested in? You don't even have to answer now, but again, these are just something to think about when you then speak back to your colleagues as well. No? Okay. Question which is outside, sorry, I'm just reading the chat. Question which is outside of our topics for today, but just want to share and need your advice. The procedure codes. Do we have latest on the procedure codes? Sorry, I'm not too sure about any updates to the procedure codes. You're talking about medical procedure codes, right? It's only because I've been very focused on mortality coding in my work. So, COC, or you can even use the mic and speak out if you wanted to clarify your question.
Can I add to that, Kara?
Go ahead.
Yeah. Thanks, Yossi, for the question. Now, this ICD-11, I spoke mainly of the diagnosis and causes of death codes, but then the procedure codes, I think the WHO is still developing those, but they will be in a separate section. I have not gone into those things at the moment. I know you need procedure codes also for FSM, but that will be a separate section. COC. Thanks.
Any other questions? Before I just sort of highlight the ICD coding sort of areas. Thanks for the advice. Yeah. And yeah, that we'll definitely try and see the latest on that. The WHO as well, we can consult with them. So with looking at your support needs for ICD mortality coding, again, there's a set of questions on sort of training needs and capacities, and then preferences as well. So whether there's an interest or a need to have certified online short courses as well. I could speak a little bit more about that in the later slide because of the curriculum that has been developed by BAG partners as well. Automated coding tools. We briefly highlighted that we can go through them in more detail in later workshops as well, in terms of how to use them and in practice as well. Staff attachment programs for coders. So I think for some countries like in Samoa and perhaps other countries, there's, as an example, they've used staff attachment program. They've had that staff attachment program to for coders as well. Regional coding center. So some countries have as I said, expressed my interest in having off-site coding due to limitations because they, especially for countries with really small populations, they have an insufficient volume of death certificates for coders to maintain their skills and to perform accurate coding. And there are staff turnover issues and as well as the issue of the sustainability of having external support and experts to deliver on-site technical assistance as well on an ad hoc and periodic basis as well. So that's the idea of having this regional coding centre. If you're unfamiliar with the idea, the basic idea is to have that technical support for ICD coding on an off-site mode rather than providing on-site specialist coding training. And that sort of off-island, off-site coding would be centralised at a regional centre, which would be coordinated by SPC and supported by BAG technical partners as well. It has sort of been discussed in various meetings and stakeholders over the years. And the previous work prior to this project has advanced and come to a point where there has been an initial proposal for it, which is why I'm raising it now in this webinar. But there is still that need to further discuss the operational procedures with countries, the sort of specifications about the data and how it would really work in practice. Those sort of data templates and protocols really need to be adapted for specific countries to meet different coding data qualities and coding needs. And there's an obvious need to obviously consult the ministries of health around the data processing, the standardization procedures and so on. That would be conducted through the training delivered by the program as well. So there is that real need to develop all that. But that's right now, I'm just highlighting it because once those sort of consultations take place and there's the finalized proposal for it within countries, the implementation of those proposed activities would serve as a proof of concept to of the sort of the viability of having this regional coding centre and its potential to add value to improving the availability and quality of cause of death data as well in both countries and in the region as a whole. We can definitely talk more about it, and upcoming workshops will be dedicating time for countries to also look at the different support models that such a coding centre would be able to have and provide for. The other point was, with the automated coding tools, I just do want to say that there are various programs in place like IRIS and so on. And they all help to ensure sort of, standardized coding, comparability of statistics and data, and they do, bring greater efficiency, but it doesn't remove the need for manual human coders as well. So I actually do want to highlight that. So there is still that need for training in some way, for specialist training for human coders. But some countries might be interested in having the implementation of automated coding tools. Did people have any questions about that before I move on to the next again, these are sort of just stimulating your thoughts about how the different support strategies that have been proposed in the past and how that might, you might be interested or there is a need for them. I think Siosi put in the chat asking, can FSM join the coding in March 2023? Well, there is a reason why we've talked about it. Yeah, I would say so. Let us know more through the emails as well. Someone did a thumbs up, but yes. Was there specific questions? But I just hope I've clarified some of those support areas, and if things aren't clear with both the certification support approaches and the coding, feel free to contact us. Okay, so I've sort of put this in here. Again, there's also another question in the questionnaire just asking what some of the challenges that might be faced in countries to producing quality cause of death data. So we have about 20 minutes left, but we can spend like a little bit here on thinking about it. I've collated a few examples, but if there are raise your hand or turn on the mic if you can identify or provide your experiences, insight in specific challenges to producing quality cause of death data. I feel like I've done a lot of talking, so it's also a way for me to rest. Well, there's, as sort of highlighted with Nandalal, go Tanya. Tanya, you've raised your hand.
I am. I'm just trying to figure out my microphone and stuff. And my apologies. This is not really my special area of work at all. I mean, of course, it falls under the initiative, but it's not really where we have most of our technical expertise. So I'm just wondering, regarding the shift from ICD-10 to ICD-11, do we have an overview of which countries are kind of focusing on ICD-10 and which ones are more going to kind of go directly to ICD-11, or is that something that anyone has an overview of? Because I'm just thinking that training-wise, it makes a big difference, right?
Exactly, and thanks for highlighting that too. So yes, there is that need for, I guess, that landscape sort of review of all the countries, whether they are where they are at in ICD 10 or 11. So that really hasn't been done, but it's just giving them the information that's out there to help them. And we also providing question about which they're using ICD-10 now, but where are they at in thinking about implementing ICD-11?
And maybe a related question. Considering, I mean, there aren't that many countries. I don't know, actually, I don't know any, but that's probably because of my ignorance in this topic at all, in general. But there aren't that many countries that have fully gone ICD-11 yet, right?
No.
Which,
no.
yeah. Okay, good. I'm not completely off. That's good.
No, but there has been a lot of awareness raising.
Yeah. So my thing is my worry there is also about what does that mean for training capacity. If there aren't that many countries that are already there, how many people do we actually have to rely on to support with this training on ICD-11? Sorry if I'm asking odd questions. It might just be complete due to me not being an expert in this area.
Can I answer that question, Kara?
Oh yeah, of course.
Yeah. Thanks, Tanja, for this question. Now, the WHO has said that the countries should go into ICD 11 on 1st of January 2023. So, although they have produced this to the World Health Assembly in 2017, they took a decision. So earlier they said we have to go in 2020, but since the tools were not ready, they postponed it. Now they want to implement it in 2023, but there are few issues still. One thing is the DORIS tool, the automated mortality coding tool, which is called the DORIS tool, is still not finalized. So we are unable to use this automated ICD-11 mortality coding tool yet. Then for ICD mortality coding, ICD-10, we had this automated coding tool called IRIS. So for this IRIS, there are two tables. Like there are some tables called the MMDS decision tables. So those decision tables are fully prepared for ICD-10, but since the codes of ICD-11 is totally different from ICD-10, these decision tables has to be updated for ICD-11 coding, ICD-11 codes, and that is also still not ready. So the countries where there is countries like Australia or USA or UK who are using fully automated ICD-10 is still not ready to go for ICD-11 because these decision tables are not yet finalized. I think James will give you a better description of that because they know the position better than me in Australia. So this is why the countries still don't go to ICD-11. So they will some in my opinion, for example, Sri Lanka, we will not go into ICD-11 till we get these decision tables compatible with ICD-11. I hope I gave you some explanation. Thanks.
Thank you.
James.
Hi everyone. Sorry, James here from the ABS in Australia. I just thought I'd quickly make a comment and thanks for all those comments around ICD-11. Just from the point of view that ICD-11 is certainly, it's been adopted, it's ready to go, but I think all countries are considering their journeys towards ICD-11 might be a nice way of putting it. And part of that journey is the implementation of tools to support coding using ICD-11 and reporting to the WHO. And look, yeah, you're absolutely right. IRIS and DORIS, there are projects underway, both with WHO and with the IRIS Institute in terms of developing those. But I just thought I would also make a comment, partly that WHO would have a lot more to say on the support around ICD-11, and I know that they are providing training and support where it's being requested, but also from the mortality reference group perspective. So part of my role is as co-chair of the mortality reference group with the WHO. And there is a really large amount of work going on at the moment looking at adoption of ICD-11 and the various coding examples, things that need to be worked through, refinements to the reference guide. So there's no changes to the coding rules, but it's really important that we've got lots of work done in terms of people doing coding using ICD-11 and providing feedback on interpretation of rules in any areas, as you say, where the classification may have changed. So I think it's a big journey for almost all countries to think about ICD-11, to think about its the timing of adoption and what the steps might be. And I think it's important to engage with that conversation, but it will provide opportunity in the future. It's probably something that we all need to be aware of, but it's going to be a little bit of a journey for most of us, especially because we also need support, not just to get there, but support once we're actually coding using ICD-11. I might leave it there. Back to you.
Thanks, James, for those comments. Yeah, it's a journey for all countries, and and so we're willing to support the countries, especially Pacific countries, on that journey when they step into it. Okay, we've got about 10 minutes. I just wanted to show this slide, just more of an announcement about the curriculums, which I've alluded to in previous earlier in the webinar. So the training curricula, they haven't yet been formally included or institutionalized in universities like FNU, but there are ongoing discussions as well, and interest in having them adapted into in more online self-paced short courses as well. I've put this slide in just to kind of ask how we can help support the continuing development of and knowledge sharing of trained individuals, especially beyond or outside of training workshops. And these are sort of a couple of ideas, like having an online forum for trained individuals. I know that it's current practice for email exchanges. So like Nandalal would be able to speak to that, and he continues to engage with coders or certifiers who have sort of unclear cases, and they sort of exchange emails with him. So I've just put that out there. Oh, sorry, Gillian.
Sorry?
I'm no longer sharing my slides.
Oh, I'm sorry. I don't know what I hit. I didn't mean to interrupt you. Sorry.
No, that's okay. I'll just quickly okay. Yeah, so can everyone see this? Okay. So and then perhaps like informational videos as well that we could as an idea that could be easily shared with your peers or trained peers as well, or just sort of as a reminder, as like an advocacy tool as well, to communicate the importance of good quality cause of death data. But yeah, please feel free to share your thoughts with us, and I will add that we may refine and update the questionnaire over time. But if that's something, having a questionnaire conducted periodically or more regularly in the future and made more accessible to address your needs much more efficiently, if that's something you're interested in, again, let us know. And I've also just put in a few of the abundant relevant tools that are available now, which is absolutely great. And I've just sort of put them in the slides, and we will upload them on the events page as well. As much as they're great and having these resources available, there's always a need and an interest by countries to have them adapted to local contexts and infrastructure So we are mindful of that, and if there is a need for that, again, we can try and support you. So these are some of the tools. And this is the final slide. Contact us. I think I've said that a number of times if you're interested in any of the things we've presented in this webinar. Another reminder to fill out the questionnaire if you are interested or in need of support in a lot of those technical areas in cause of death certification and coding. Submit it to us, SPC, at the earliest time that works for you, and note our upcoming events and workshops. Dates are on the slide, and I will give Mike the final word. Thank you. If Mike is there.
I am here. Thanks so much, Kara and Nandalal, for the great discussion and informative presentation. Hopefully everyone got a lot out of it. I was glad to see the questions in the chat, and also the interest in the upcoming series of events. So most certainly I reiterate Kara's last words that if you are interested, please reach out, and we'll do our very best to make sure you can participate. Once again, thank you for joining during, we know it's a busy time of year, or a time to at least wind down. So we very much appreciate that. And we look forward to continued engagement with you. I think I can see Nandalal. Do you have any final words that you'd like to say before we say our final farewells?
Well, not much. First of all, I would like to thank everybody for joining in during these festive times. I know it's almost holidays for the Pacific, and I would like most of you, if you can join in the in-person workshop during February and March, it will be great. So I'm looking forward to meeting you in February and March during this in-person workshop in Nandi, Fiji. Thank you. Thanks, Mike.
Okay, thanks a lot. And yeah, once again, very much appreciate you all joining, and we'll look forward to the collaboration next year. Wishing you all a happy holiday season and a happy new year. So thanks again, and we'll see you next year.
Thank you very much.
Much appreciated, Nandalal,
Bye.
Kara and Scott, for the great organisation. That was wonderful.
Thank
Goodbye,
you.
everyone.
Bye-bye.
Thank you.
Take care.
Bye-bye.
Bye-bye. Happy holidays.